Hi everyone, I'm going to talk about antifungal stewardship today, which is a subject close to my heart. I think it's something we really need to progress to improve our overall management of invasive fungal infection. Here's my disclosures. So what about antifungal stewardship? It's really very similar to antimicrobial stewardship in some ways, but slightly different in others. So in summary, it's a multifaceted approach to optimising antifungal use through implementation of evidence-based guidelines, improving access to diagnostics, and careful prescription review. So the aims are very similar to the aims of antibacterial stewardship: to reduce inappropriate use, optimise outcomes, ensure cost-effective therapy, and minimise harm. However, the challenges for antifungal stewardship are quite different. This is just a little comparison really about antibacterial stewardship and antifungal stewardship. And when we think about it, there are quite some differences. And this really shows that we need to approach antifungal stewardship in a slightly different way. So the specialties, of course, are all immunocompromised patients, and we're not the primary carers for these patients. So very important that we engage with the specialties managing these patients. The indications, rather than treatment with antibacterial stewardship or single-dose prophylaxis, we often have extended periods of prophylaxis, which can merge into treatment in a patient who develops a breakthrough infection. So it's not always clear-cut where the patient is in their prophylaxis and treatment journey. This means that the courses of antifungals are often more prolonged than what we would see with antibacterials. And whilst there are fewer agents to be covered in antifungal stewardship, there's really more complex PK with multiple drug interactions with the complexities of the patient groups receiving these antifungal agents. And of course, toxicities can be really significant in this group of patients. So again, just a slight contrast to what we see with antibacterial stewardship. Of course, I'm probably preaching to the converted because we don't really need to justify it, but in case we do, we can talk about the high costs of invasive fungal disease. And in one study we did in Australia several years ago now, the mean attributable cost was nearly $80,000 for a haematology patient developing an invasive fungal infection. Of course, there's the poor outcomes that we see in our patients with invasive fungal disease. There's the increasing use of antifungal agents with a lot of prophylactic and empiric use, and opportunities to de-escalate therapy often being missed. And then unintended consequences, particularly within a hospital ecology where there's a massive use of antifungals, we'll often see emergence of more resistant organisms in that hospital. So what does antifungal stewardship look like? And there was a very nice review of this recently published in JID, talking about what we should be aiming to do in our antifungal stewardship teams and activities, and breaking it down into what's essential, what's achievable, and what we should aspire to. And I'm not going to go through all of these, but it's a very sensible breakdown of the types of activities we should be doing, including getting our institutional pathways and bundles for antifungal prophylaxis and treatment, developing education, reviewing post-prescription review and review for drug interactions, doing post-prescription review rounds and feedback to the prescribers, switching to oral whenever we can, so doing an oral switch approach, and local surveillance. And of course, the achievable tests, the achievable often rely around timeliness of reporting on diagnostic tests and on antifungal susceptibilities and on therapeutic drug monitoring. And so this obviously is something that's achievable, but as I'll show you later, still a way off for many of our centres, and aspirational is really taking a national approach or a regional approach. So being involved in surveillance programs and developing individualised risk assessment for our units, and utilising more personalised approaches to therapeutic drug monitoring and diagnostics. So again, these are all things I think that we should be aspiring to in our antifungal stewardship programs. Again, an earlier study actually went through many of these by Patricia Munoz and colleagues, talking about, and I like this pyramid approach because these are the things that are quite a lot easier to do, to create a group of people who are involved in stewardship, including the prescribers and the primary care teams, doing audits to look at what your rates of antifungal usage are and where the gaps are, education, guidelines, alerts, and defining when a patient starts an antifungal, rapid testing and bedside interventions. And I think this shows it nicely because these are always the hardest things to do, particularly the bedside interventions, requiring time and a team being able to get out there and talk with the prescribers and the caring teams. Looking at what's the state of play internationally, I think this meta-analysis was done in 2018 and published, and really shows that there's quite a long way to go in developing standardised metrics and standardised interventions internationally. So many publications describe stewardship as a multifaceted intervention, but various metrics are being used in these studies to measure outcomes, largely cost and antifungal drug consumption, which of course doesn't relate at all to the quality of the prescribing, and patient outcome and data are lacking. So this meta-analysis and review did say that it's actually quite difficult to evaluate antifungal stewardship programs because of all these varied metrics and approaches that are being taken. Well, in Australia, we did a survey. Karen Abanchik, a PhD pharmacist, did this survey of both principal referral hospitals and other hospitals, and showed that, again, in our setting, principal referral hospitals do tend to monitor antifungal stewardship and antifungal prescribing more often than non-principal referral hospitals. But all hospitals really focused on the less resource-intensive monitoring, that is, monitoring cost, antifungal drug usage, and doing point prevalence surveys. So less intensive than doing constant monitoring and monitoring the quality of prescribing. Similar findings were found in other international surveys. One looking at English trusts showed that antifungal stewardship programs were actually quite rare in this survey in 2017, and they were often part of, where they existed, they were part of an antimicrobial stewardship program, although 20% said that they didn't have any antifungal stewardship at all. Most said they would do more, and the reason why they couldn't do more was lack of staff time, competing priorities, and also a perceived lack of importance. I'll just skip over that. Sorry, I'll just go back to this one. This is a survey in the US, and this was a survey in 2016 of transplant centres, and looking at overall antimicrobial stewardship, not just antifungal stewardship. And many of them had guidelines in place, education and dose optimisation, authorisation, but very few measured anything besides the cost of these interventions and the cost of antifungals and drugs. And what was very interesting, and I think this is the case for many different centres, is that when you look at the diagnostic capabilities of therapeutic drug monitoring, these were often send out tests, send out here in grey for drug monitoring, and send out here for galactomannan. So you can see that many of them had these tests available, but they were sent out, which is often the case in centres in Australia as well. So from reviewing this data, one can say that there is really some structural and process defects in antifungal stewardship programs internationally, and that there is a lack of outcomes, particularly outcomes relating to quality of prescribing and patient outcomes. So this led us in Australia to look at a process where we could try and develop some core metrics for antifungal stewardship and metrics to monitor the impact of antifungal stewardship programs. So we called these core antifungal stewardship metrics, and we wanted to develop these in the area of both antifungal usage and consumption, quality of antifungal prescribing, outcomes, key outcomes for patients, and the feasibility of actually doing this type of monitoring. And so we conducted a Delphi survey of international experts, which was published by Anna Kanina in 2021. So we used the Delphi methodology, and this is a very nice process, and it was actually very educational and useful to do this process. So we had a number of experts in the field of antifungals and antifungal prescribing, and these facilitator and the steering group undertakes the initial literature review and finds what should be the core metrics, what have been published as metrics for stewardship, and then send these out to the experts to review and rate according to their importance. So these responses then go back to the facilitator, who summarises them and then sends them back to the experts saying, well, 80% of people thought this was important. Do you still rank this highly, or do you not rank it highly? And give people the chance to modify their views until a final report is developed. And the way that this is done is really quite useful because it's anonymous, and we all know that often people who are very influential can influence a group to agree with something when they may not actually agree with it. So doing it in this anonymous way makes it very useful for people to actually give their honest opinions. So a database search was done and articles were compiled relating to antifungal metrics, and they were divided into the areas of antifungal consumption, quality of prescribing, and outcomes. And the literature was reviewed, and in the end there were 13 metrics, 45 metrics and 21 metrics in each of these categories, which were sent out to the experts to comment on as to their utility, and in the final round as to their feasibility. So participants were identified according to having worked in the area and trying to get a broad scope across different geographic locations, adults and paediatrics, and different craft groups. And they were generally selected on the basis of their publication records. Overall, 82 of the 134 people consented to be involved, and 79 completed at least one survey. There were 3 surveys sent out, and the completion rate was actually very high for all 3 surveys. What did we find? Well, in the end, we looked at metrics with high importance and moderate to high feasibility ranking. We had to really discard those metrics that were thought to be important, but everyone said that it wasn't very feasible to collect them. So these metrics here were not really included in the recommendations. So on this side, you can see the types of things that were thought to be feasible and thought to be important. And much of it relates to the quality of antifungal prescribing, although there is some relating to how you would capture the work of the antifungal stewardship team, how it would capture the quality of prescribing, how you'd capture whether adequate diagnostic tests were being performed, and the adequacy of antifungal therapeutic drug monitoring. And in the end, clinical outcomes, including the incidence of invasive fungal disease according to bed days, and microbiological outcomes such as causative organisms. Although it was thought to be very useful to capture mortality related to IFI, I think everyone concluded that this was not something that a stewardship team could easily do. There are a number of barriers identified, and I won't go through them all, but they're the common themes that often come up: competing priorities, lack of financial resources, difficulty in extracting the information, particularly relating to treatment and diagnosis and outcomes of fungal disease. And this was particularly difficult where there's no electronic medical record within an organisation. Also, the unavailability of personnel or the expertise of personnel to be involved in these programs. And then the issues around the complexity of the analysis and data completeness in the case reports or in the medical records. So in conclusion, 38 metrics were agreed to be important, but only 21 had moderate to high feasibility. And we think that these metrics will provide a framework to comprehensively assess the quantity and quality of antifungal prescribing, and will assist us develop quality programs to look at stewardship and to develop stewardship programs. We also, which I'll talk about a little bit later, plan to develop an antifungal stewardship module in our national antimicrobial prescribing survey, applying the findings from this Delphi, which I'll talk about in a moment. So in antifungal stewardship, I think we'll all agree that there are a number of challenges to be overcome. Obviously, antifungal prescribing is complex. It's more intensive doing antifungal stewardship than antimicrobial stewardship. We need better outcomes to determine the quality of prescribing, which are currently not well collected, but which we think we can construct from the findings of this Delphi. And of course, the best model of antifungal stewardship is not really defined at this point. So what do we think we can do about this? I think we really do need to take a more systematic approach to antifungal stewardship, looking at these metrics that have been outlined as being feasible for us to collect. And we do need to put resources into these programs. Some of the things that might help us in the future are developing automatic surveillance for invasive fungal infection. And our group has had some success in doing this using natural language processing as a way of screening reports. We've worked on both radiology reports and histopathology reports to try and pick out those reports which are indicative of fungal infection. And if we had this type of a tool in our hospital, we could do constant surveillance for invasive fungal infection. So there's still some work to be done on this, but it seems to be a better approach than trying to extract every single case of invasive fungal infection from case records, which is really not a sustainable process. The other is to look at quality of prescribing audits. They could be drug-directed, they could be bug-directed, or they could be ward-based, like looking at a haematology ward. And so with that in end, we're developing an antifungal module for our National Antimicrobial Prescribing Audit, or as it's known as NAPS. And this currently is a survey that many hospitals around Australia participate in annually. to collect data about the quality of antimicrobial use. There is an aged care NAPS, there's a surgical NAPS, and we hope to develop a fungal infection NAPS so that we could have national benchmarking of prescribing for antifungals. So that is probably the way of the future, and I hope I've been giving you some food for thought about antifungal stewardship. And thank you. I will end my talk there, but just briefly acknowledge Anna Kanina, who's a clinical pharmacist and is managing our antifungal stewardship project. Prof. Karen Thursky, who's Director of the National Centre for Antimicrobial Stewardship and leads the antifungal surveillance and stewardship project that we're running, and Ms. Karen Bernchik, an AMS pharmacist also and PhD student. So I'd like to thank these colleagues of mine who've helped provide data for this talk today. Thank you very much.